Good evening, everyone. Welcome to the Deakin University Optometry Alumni webinar, Double Trouble, where we will be bringing you insights to those scenarios in clinical practice where you may have to think twice with the help of our presenters, Natalie Dowling, Geoff Sampson, and James Armitage. I'm Zara Dineshvar, your co-alumni president of Optometry of the Optometry Alumni Chapter, and today we are broadcasting live from the Warm Ponds Estate at Deakin University with the Alumni Committee members Amanda Edgar, who's our co-president as well, and committee members Ash Chan and Lucy Ainge. Feel free to follow the link emailed to you for your inter-dashboard to fill out your questions during the presentation tonight. If you have done the CPD with us before, you would not have received this email, so you can use the same logins that you did last time. Nothing would have changed. I'll pass it over to Amanda, who'll be taking over now.
So today's webinar will be recorded and posted online on the Deakin alumni website, just like last time, under webinar and resources. Please allow 3 to 4 weeks before this occurs following tonight's presentation. So thanks for tuning in, everybody. After the presentation today, like Zara said, you can claim your CPD points by filling in our online quiz. You've all been enrolled in this program before. It's Inter-Dashboard that we use here at Deakin University for our TBLs. And you should have received an email if you are new to this program. If you have any questions after tonight's presentation, please feel free to contact one of the alumni committee. So tonight's presentation will run for about 60 minutes. Each speaker will have a Q&A session following their presentation. You can ask questions by typing into this question box that you just used through the presentation, and we'll filter them to the presenters at the end of their talk. So welcome to the second Optometry Alumni webinar, Double Trouble. Our first speaker today is Natalie Dowling. Natalie graduated from Deakin University in 2017 and worked for 18 months at a rural independent practice in northeast Victoria. During this time, and due to her proximity, she co-managed glaucoma with ophthalmologists and treated a vast range of challenging therapeutic cases. Natalie is continuing to further her experience, living the life of a locum optometrist through Queensland and New South Wales, part of which involves working as a clinical optometrist in a visiting clinic alongside ophthalmologists. Natalie has also completed the ACO's Advanced Certificate in Children's Vision. We are lucky to have her here tonight and her contagious passion for rural health and therapeutics. Thank you so much for joining us today, Natalie. I'll now pass it over to you to begin your exciting presentation.
Hello everyone, I hope you can hear me. Thanks for the introduction there, Amanda. As Amanda said, my name is Natalie, and tonight I'm just going to be having a little bit of a chat to you about dealing with topical drug shortages, which I thought was something of interest at the moment, just because over the last 12 months we've had quite a few shortages, beginning with the Virax getting discontinued last October, and then more recently having shortages of both FML and then more extensively of Virax this year. So just wanted to have a quick chat with you tonight about what I've done in situations where I found myself either feeling like I wanted a drug that I didn't have, or worried that I was going to lose a drug that I really wanted. So we'll jump right in. Just a little bit more background on where I've been working. When I graduated, as Amanda said, I was working in my hometown of Yarrawonga, which is that little red dot there. It's a small town of about 7,000 people, and we were the only optometrists in the town. So in terms of ophthalmological support, just a little bit to the right and down, we had one opthal in Wangaratta, and then over Albury Wodonga, which is just further over to the right, another border town. There was a group practice of about 5 to 6 opthals there. So if you look at that red circle there, you can see we had about 7 opthals kind of servicing this area, which is quite highly populated, about 200,000 people. So you can imagine there'd be those ophthalmos are pretty under pressure, pretty full up. So there was a great learning experience for me, because they were quite happy to co-manage most things, especially more complicated therapeutics cases. Really happy to get on the phone, which really helped for us, but also gave them a lot of help in terms of relieving a bit of that stress for them. So tonight I'm going to be going through 2 cases. The first one, I saw in Yarrawonga. So we'll jump in, and just before I start talking, my photos here aren't of actually my patients. They are just ones from the interweb, because I wasn't able to get a hold of my old anterior photos. So just excuse, I think this is a left eye, and we're talking about a right. So just getting a bit of an idea there. So case 1, about 18 months ago, as I said, I had a 92-year-old female present to me, who was complaining of some blurry vision and a sore right eye. Not particularly painful there, but other kind of interesting history was she was on a multitude of medications, which, given her age, is unsurprising. But about 2 weeks prior to her presentation, she'd begun on a new sleeping medication, which she really felt was knocking her around, and she was becoming quite drowsy throughout the whole day, and sleeping exceptionally heavily. Other ocular history that we found important, just she had some bilateral IOLs and a bit of dry macula there, so our vision wasn't going to be 6/6. On clinical presentation, right eye was quite down. We had 660 in the right eye, no improvement on pinhole, and 6/9, which was normal for her in the left. And when we stained her up, we found this huge epithelial defect taking up most of the cornea. It was only epithelial, but it was large. And then there was quite a lot of corneal edema, which was accounting for a lot of that reduced vision there. Pressures were normal. What we could see of the anterior chamber through that hazy cornea looked okay, but it was mainly this big epithelial defect that we were interested in. In regards to differentials at the time, we're thinking something probably traumatic, just because of the sudden onset and that appearance of the cornea. So we're looking at probably an acute corneal abrasion, or even considering it as something more recurrent, like a recurrent corneal erosion, but that'll be very, very large for that, but it could be. So I diagnosed initially an acute corneal abrasion, and treated quite conservatively out there. I think just with a bit of caustic ointment 3 times a day, as a bit of prophylaxis, and also keeping that eye nice and moist. And then also some preservative-free lubricants hourly, and set the review for 1 day, just because of that vision being so poor. So following up 1 day later, things were going pretty good in terms of how our patient was feeling, and her vision had picked up there a bit. You can see there 630, so much better than 660, but not ideal. But what did concern me was there was this central area of a line staining, which appeared epithelial, kind of like it was I don't know. You can kind of see what I'm looking at there. So it's raised area centrally with these bulb type endings. So pressures were good. Anterior chamber was fine. So have to reconsider our diagnosis here. So first of all, could be the corneal abrasion just healing over, because quite often when you've got such a large abrasion, the cells can kind of clump up where they're trying to re-adhere and build up. But we had to introduce a new differential of a secondary traumatic herpes simplex keratitis, which, given her age and potentially her immune system, given her age and medications, could be quite reduced. So that was our other differential. When I go treat this, I had a chat to my mentor at the time, my boss, and I also had a little word on the phone with the ophthalmo who was 40 minutes away. And we all decided the best possible thing to do here was to treat as though we're treating for the worst possible outcomes. So if we overtreat it with some acyclovir at the time, it wasn't. We weren't going to cause, hopefully, any long-lasting effects. But if we were to leave this and just treat it as though it was that abrasion healing, more likely to have, we're more at risk of having reduced vision in the future if that one goes untreated. So that's what we did. We treated it with Zavirax 5 times a day, and we decided to review that following day. On the following day when she came in, there was next to no corneal staining. That line stain, that epithelial defect there had kind of healed over, and the vision was back to normal. So that was pretty conclusive to us that perhaps it wasn't a secondary HSK. Reason being is that something of a HSK of that size generally wouldn't be able to heal overnight. That would be something that would take a little longer. So ongoing, we just popped this patient on some gels at night, and she wrote a letter to her GP, and she was going to have a bit of a chat to her GP about maybe preventing this in the future, because we did think it probably came from her being knocked out from those new sleeping meds and maybe just brushed across that eye, causing this staining, causing this abrasion. So you might be thinking at the moment, well, you obviously had Zavirax here. We're supposed to be talking about shortages. What's the deal here, Nat? But when I got a notification, I actually got on Facebook last year that Zavirax was going to be discontinued. This case sprung to my mind immediately, because immediately I was concerned, and I just thought, what would I have done if this patient had come in and I needed to treat her and I didn't have that available? As a 92-year-old patient in a rural area, well, not because she's in a rural area, but as a 92-year-old patient, her mobility was not ideal. So trying to get her off to see a GP to get some orals, especially when we're not 100% sure that's what it is a bit of a pain. Not to mention the time that it would take for if we were to decide to send her elsewhere to an ophthalmologist or something, and also the costs involved in going to see someone else if we didn't have access to that topical ointment. So I felt really lucky that we had it there, and I was a bit concerned if we were going to lose that topical acyclovir, what would we do? As in my scaredness, I spoke to my mentor, and we did a little bit of a retrospective clinical review of what we'd been doing over the past 2 years, or she was been there for 2 years. I'd only been there for 6 months. But we had a look into what we'd actually been prescribing, and we found that over a 2-year period, our practice had prescribed Zavirax 2 to 3 times per month over that period. So that's about every 2 weeks, given that 2 of those were misdiagnoses. So the one that I've just mentioned, so not misdiagnosed, but a suspected and incorrect suspicion. One there and another one by me. So my mentor was obviously a little bit better than I was, but anyway, so it was still prescribing it fortnightly over that 2-year period. So we were obviously concerned. So first thing we did is I had a bit of a chat to our local pharmacists around town, and just explained to them that that I was concerned that we would run out of this drug, and could if they were could they just keep us updated on how much they have left in supply. We ended up running them dry before Vision got TGA approved, so we were pretty happy that Vision got approved when it did. The other thing that my mentor and I did is that we came up with a treatment plan for how we'd be able to treat this if we didn't have the topical ointment available to us. So for us, that involved immediate referral to a GP for orals, and so then they could go through their current meds and see if there was any interactions there. But yeah, so referral to a GP for orals, and then be reviewing daily, which daily reviews for a HSK is not generally what I would do. Not necessarily. I might be checking a HSK every 2 to 3 days, but because we'd be possibly treating a different way, treating with that oral, something that I don't do every day, we'd be shortening those review times so that so we can make sure that this isn't going haywire and doesn't need to see someone else. Thankfully, we didn't have to do that because TGA approved Vision in a relatively short amount of time. So in regards to TGA, you might be thinking, why did we go to all that fuss of creating a management plan and chatting to our pharmacists when obviously TGA was just going to approve ASI-Vision? It was a given. It wasn't really in my eyes. The reason for that is that if you have a look at the TGA website, generally takes 12 months for a new drug to be approved by TGA, and if it's not approved by TGA, the Therapeutic Goods Administration, if you're not familiar, if it's not approved by TGA, it cannot be stocked or supplied in Australia. So that was a bit of an issue. I thought, if this is going to take 12 months for a new medicine to be approved, then that's 11 months. That's 20 cases of HSK that we're going to have to be doing all this running around, intra-referring, which is just a bit of a pain. So the reason that TGA approved this a bit quicker, a couple of reasons. Probably first, if you can see on the right, it's very, very small there, so apologies for that. I've got a screenshot there of the medicine shortages information, and that there states that in the red it says critical. So that's just saying that the loss of the shortage of this drug to the Australian market was deemed a critical impact on our patients. So TGA is going to do their best to find a replacement quickly. And also TGA had previously approved ASI-Vision temporarily back in 2016 when we had a shortage. So that's why TGA came through so quickly. But what I wanted to get from this case was that when you're in a situation where you're not sure, where you're faced with doing something that's quite different to what you usually do, the best way I think to go about it is to have a plan. So have a plan of what you'll do if you can't get access to your drug, and make sure that if you've got more than one practitioner in the practice, that you all kind of agree on that. I think is important, because then you can bounce off each other and go from there. For the sake of time, we'll move along. So we're just going to move on to case 2, which is one that I saw only a couple of months ago now, in a rural practice, southeast Queensland. So this lady presented with a left red eye. It had been there for about a week. She was noticing some occasional throbbing, but generally the eye was all right. She had no other health concerns, and she explained that she was pretty much just there because her boyfriend had told her that it was pretty red and it wasn't getting better. Her boyfriend and their family were a bit concerned. So having a look at the eye, vision was great. The cornea was no problems, and the anterior chamber was nice and quiet, but just nasal on the left cons, nasal of the cornea, I should say. The left cons, we had this raised staining lump. I've written there grade 2 Efron scale hyperemia, but we could go anything up to grade 3. I reckon it was pretty red. So just imagine in your head some really, really, really nice red lump on the end of conj. So differentials were inflamed pangueculum, because it's not encroaching over the cornea, a bit of nodular episcleritis, or more seriously, can't ignore our more serious diagnosis, differentials of things like conjunctival epithelial neoplasia. I was pretty confident that it was inflamed pangueculum. Usually I'd treat with a Flarix 3 times a day, but unfortunately this one wasn't. I couldn't get the Flarix at the time, so had to think of something else. So I discussed with my patient at the time what she wanted to do. Whether we change it to a different steroid, a weaker FML or a stronger Maxidex, or we could go for even an NSAID, but the patient really didn't seem too fast. So I said, I'll just go try some lubricants for a couple of days, and it'll come good on its own eventually. So see how you go, and just take it to Nurofen if it gets painful. But I'd set a review for a couple of days later, and in she came. Nothing had changed in terms of the clinical appearance, but the patient, I don't know if she had a party or something on the weekend, but she was noticing it more. It was getting a bit more painful. She really wanted to get rid of it. She wanted to try a steroid, she told me. So probably two main options here. I could have gone for an FML a couple of times a day, or a Maxidex a couple of times a day, and I just thought, look, if I'm going to hit it, may as well hit it hard. So just smacked her on some Maxidex 3 times a day, and thought I'd review her in a couple of days. Let her know that she should definitely call me, like I tell all the therapeutic patients that I see. If you have any problems at all, please call. Really hoping they don't call, because that means I've maybe mucked up. but she called, so that was very frustrating. And when she called, she just explained to me that when she put in the drop the first time, she, for about a 15-minute period, she experienced a little bit of nausea and maybe a little bit of dizziness. That subsided quite quickly, so she the next morning thought she'd have another go and had the exact same response of a bit of nausea and a bit of dizziness there. So she very well may have been having a reaction to Maxidex. When I looked into that, the chances of nausea or dizziness is about 1 in 5,000, so not common. So a case of a little bit unlucky, I reckon. But yeah, not common, but definitely can be side effects. So I thought, let's get her off this. In regards to how the eye looked, it was starting to look, it was already improving just after 2 drops of Maxidex, which was beautiful, but I wasn't keen on keeping her on it. So instead I dropped her off to, swapped her down to some FML 4 times a day, just that little bit more frequently, because it's the weaker steroid there. And I just explained to her the importance of doing a punctal occlusion and putting those drops in to reduce the amount of systemic side effects. And lastly, drafted a letter to her GP again, because it's really important to keep them up to date if you are kind of concerned that maybe a patient has a bit of an allergy or something to a dropper or anything. The GP should be kept in the loop for further things down the track. So the reason this one I thought I'd share with you is because I maybe was a little bit too quick on going off to the Maxidex. Maxidex isn't something I prescribe frequently. So maybe I should have thought a little bit more before I put her on the Maxidex. But bottom line was, patient came in with a problem. Patient's problem was fixed. Might have taken a little bit of mucking around, but we did fix her a problem with the FML, cleared her right up in a couple of days. So my point to you there is that when you've got a drug in shortage, consider your other options, but just go easy on yourself. We're all early career optometrists here, so go easy on yourself. If you do something and it doesn't work, try something else. It's okay. Probably don't try too many things. Maybe send them to an opto if something's really not working. But yeah, if something's not working, do try something else. Don't get too sour at yourself. So just some considerations why I thought this was still relevant, even though we've got the Flarex back now. We're only, I assume, the longest person here, other than our tutors that have been in optometry, would be less than 5 years, I'd say. Or 6 years, is it? But already we've had a couple of these shortages, and we've had this discontinuation. So these are not one-off situations; they're going to happen again. So just be prepared for them, and be positive that you'll be able to deal with it, even if you don't have your drug of choice. I would really recommend using the link just there for the TGA website. So I mentioned before the medicines shortage information site on TGA. So that was where I had the one that said critical there, down in the bottom corner here. The reason that's so good, I think, is that you can look up any drug that you think might be in shortage, or if you're concerned it is in shortage, and it'll give you some dates. So obviously for Acid Vision, it was discontinued, so there was no return date. But for the Flarex, it said this drop is likely to be unavailable from this date to this date. So if you're not sure if you've got a drug back, you can just check on the TGA website, and they should give you a good idea of what to do. There. Sorry, I've just had something pop up on the side from a question. So the other two I've touched on there. So don't be afraid to change your management plan. You're qualified, you'll be all right. And just lastly, if you are going to change your management plan, understand that you haven't done that a million times maybe. So maybe monitor it that bit closer. So yeah, that's all from me. Please chat through some questions. And I'll do what I can to answer them. So, actually, here's some references I used. That TGA one more, probably important there. So So I've just got a question here. How do you decide which steroids to change to, i.e. Predfort versus Maxidex? Well, great question there. It's all to do with penetration. So obviously the well, not obviously, you may not know. The Predfort's going to penetrate deeper than the Maxidex. So personally, as I said, I don't use Maxidex very commonly. For anything like a uveitis, I'd be going for Predfort. I really, to be honest with you, the only times I'd use Maxidex before working with the opthal is for 1 month post-ops and treating for CMO, because generally they've been on Maxidex post, not generally, some opthals will put them on Maxidex post-cataract surgery. So if they've got CMO continuing, I'll continue with the Maxidex. But other than that, I don't really use it very much. Yeah. Any other questions? Chuck them in the chat and I'll do my best. Is there an over-the-counter acyclovir tablet in Queensland? That is a good question. I should know that, and I don't. So, yeah. Cool. I'll stop there. Thanks, guys. Hope it was okay.
Thank you for your insightful presentation. It's now time for our next presenter. Our second presenter for tonight is Professor James Armitage. James graduated from Melbourne University in 1996 and has completed a Masters of Optometry and PhD in the Department of Optometry and Vision Sciences at Melbourne University. After a postdoctorate fellowship at King's College London and the Baker IDI Heart and Diabetes Institute, he joined Monash University as a group leader. He joined Deakin in 2012 and his clinical interests include dry eye and glaucoma. James' optometric research is seeking to understand the modulators of ocular blood flow and how they affect the eye. We are so fortunate to have his expertise with us tonight. Thank you for your insightful presentation. So I'll pass it on to you now.
Excellent. So it's a fantastic, exciting day to be able to be speaking with a couple of graduates. So speaking with Nat today is super exciting, and also it was really exciting about a month and a half ago to be able to speak or be taught by Amanda and Hayley at a concert event. So it's lovely to see whatever it was, about 129 of you up there, 130, so that's awesome. What I'll do is talk to you a little bit about glaucoma. I know you've heard lots of it, but this is a kind of a messier case, and it's something to think about. So I will begin by acknowledging country. I guess we're all around Australia, and so I'd like to acknowledge the Indigenous people from wherever we are. I'm at the moment in Eden on my holidays, so I'd like to acknowledge the Yuin people, as it's their land that I'm presenting from, and I pay my respect to their elders past, present and emerging. Okay, so let's think back to the good old days when I'd throw up random pictures and you'd ignore me randomly. So we can repeat that all over again. Let's have a look at this lady who came in to see me. I have permission to show these pictures. These are some images from the left eye. It's just another disc image. I think you've probably seen hundreds like these before. And when I looked at these, I was kind of a little bit curious. I thought that the superior rim was just looking a little bit different. Inferior looked okay. It just didn't quite gel with me. And so when the patient had some other risk factors, had thin corneas, she'd not had glaucoma before, she'd not had any risk factors that had been measured at the practice where I'd seen her, other than slightly large cup to disc ratios, which were mentioned. So I'd say this is a kind of a normal size disc, nothing too massive. Superior rim just a little bit thinner, superior temporal than I'd like to see, but otherwise nothing dramatic, around a 0.5, 0.6 cup to disc ratio. Couldn't see anything else of concern. So From this, you know, I don't know, are you concerned about this? Would you be concerned? I don't know. I can't actually see any of your responses, but it'd be worthwhile just, you know, typing in whether you think you're worried about this or not. Notwithstanding, threw her on the OCT because I was just a little bit unhappy about that appearance of the optic nerve. So I'm sure lots of you have got OCTs in practice now. This is, as I said, not a massive disc, sort of, you know, medium sized. I thought, as I said, the superior was just a little bit thin, and actually, when you look at the T-SNP plot, she's sitting largely in the green there, which is in the normal range. But I still, you know, I just got a feeling about that disc, and I wasn't overly thrilled about it. I'm a left-hander, so strangely enough, I start looking at I drive the sit lamp with my left hand most of the time. It's my preferred hand, so I tend to look at the left eye first. And you know, I just thought the inferior rim there looked a bit smaller on OCT than it should be as well. But nothing really massive that I was concerned about. One thing I think it's important is that if you're looking at OCT and you're just looking down at the colours, that's a fully green OCT plot. So it'd be probably easy to just say, yeah, that's fine, nothing to worry about. But I was a little bit worried about the superior rim. I think it's thinner than it should be, even though it's within the in the normal range. Cut to disc ratio is around 0.6, so you know it's not a it's really not a huge cut, but it's a 1.5 disc, 1.56 millimeter disc. So you know, not great. I'm just a little bit worried. So being a little bit worried, I also did a ganglion cell, so a vertical scan on the machine that I've got in the practice, and largely it didn't really come up with anything either. By the way, when I look at ganglion cell, just getting my arrow here, my laser pointer. When I look at the GCC, what I look for is, you know, that C shape is kind of normal, and I'm looking for a chop out either superior or inferior. So in this eye, I guess the superior rim was just a little bit thinner than I wanted it to be. So I'd be looking for a chop out of the ganglion cell layer superior, and I wasn't really seeing much there. So I don't know, would anyone do anything on this other than watch? Does anyone? So you've got that sort of suspicion that there's something going on. Would anyone want to treat on this? Again, I can't hear or see what you're doing. I'm just going to wait on Luce to give me a bit of a feeling about if anyone wants to treat on this, or if you're going to watch. Who's, you know, just type in watching, checking, check on the other eye. Yeah, definitely. All right, so let's check on the other eye then. So, by the way, we did a field on this. This is the left eye field. It's their first field. There's a few scattered losses. By the way, we know that 3 contiguous spots at 0.05 are pretty suspicious for glaucoma, providing it's repeatable. So when I did this field, it didn't make a hell of a lot of sense. I mean, the superior rim was the one that I thought was a little bit worse. There's lots of points. There's 1, 2, 3, 4, 5 points in a row that are pitch black on the pattern standard deviation. So I'm a little bit concerned still. Does anyone want to treat on this eye yet? Or are you still happy to hang out and wait and see? Who wants to? Why don't you type in treat or hang out? So at the moment, I decided to hang out because I I wasn't quite sure I really could do anything about this. Incidentally, we repeated the field in this eye, and it was sort of the same, but not the same. Still a couple of points, but not. It didn't actually look that bad second time around. So then we went to the other side. Yeah, so we repeated the field and got some similar things, but nothing jumped out. So then we went to the other eye. What do we think about this right eye? So we've got a right eye, same person. Is anyone worried here? So hopefully lots of you have seen it. It's probably easier to see in the red 3, but yeah, look at this wedge defect down here. So this to me set alarm bells ringing, and pretty much it's sort of, for me, this is, we're now, tell me it's not glaucoma from now on. So, you know, when we look for glaucoma, we look for, is the isn't sign obeyed? But we know in 30% of people who are normal, is not obeyed. So there's kind of, you know, it's a good sign to look for, but in 30% of people who fail to respect the isn't rule, don't have glaucoma. We know that hemorrhages, Grant hemorrhages, are a pretty strong bit of evidence. But we also know that whilst when you get a Grant hemorrhage in glaucoma, it's really, really important, the statistics tell us that up to 60% of Grant hemorrhages are not due to glaucoma. They're just idiopathic. They just happen. So Drances aren't the sort of cross-sectional, I'm going to jump the gun for glaucoma. Field losses, as you all pointed out, field losses are a real mess. Our patients, you know, they're not great at doing fields. But if you see a wedge defect like this, that should be your best and happiest. That's what you should be happiest treating on. So I didn't bother repeating fields. Of course, I have repeated fields and done a whole bunch of stuff. As soon as I saw this, that turned to me into this is glaucoma. And interestingly, if we look at the T-SNP plot here, because again, if you're in the habit of looking at the colour codes, other than a teeny tiny little wedge down the bottom, this is all pretty much sitting in the green still. So again, this is a really important bit of information. Like, don't look at the colour codes particularly. Just because it's red doesn't mean they've got glaucoma, and just because it's green doesn't mean they've got glaucoma. This is actually a slightly bigger disc. It's around 1.7 millimetres tall, and a 0.7 cup to disc ratio, but it is definitely thin inferior. And you can also see from the RNFL, it's thin as well. And here is where the GCC is looking very, very suspect as well. So here you can see that C shape has been chopped out inferiorly, and this is a classic wedge defect. So for me, this is glaucoma. We then did all the rest of it around classifying and staging. The disc matches a field, and again, so this is a much better field actually than the other eye, but it's definitely glaucoma, and this was very repeatable. So I repeated this field, and it kept on banging up here. So I guess now, who's treating this and who's referring it and who's going to do what? So just write treat, refer, or perhaps review if you want to review. What do you reckon? Notice it's a pretty good field. So for me, this is so there was some people are saying refer, some are saying no OCT, refer, not quite sure what the shorthand for that is. I'm just getting your questions coming through, or your comments coming through to me. So yeah, this one I just started treating. I didn't bother about sending her off to Andrew Narita for him to tell me that it was glaucoma, because I already knew it was glaucoma. There was really no need for do anything else. So I decided to treat this, and the reason I decided to treat it is that we have a wedge defect. There's very glaucomatous in nature. We have a field defect that matches the wedge defect. And then, by the way, her cornea was thin. She's diabetic as well. And you'll see that field had lost quite centrally. So my thought was, we're going to have to go for a 30% reduction. I phased. I can't remember when I first saw the patient, but I certainly saw her next time to repeat the field and repeat pressures. Highest pressures I could find were 17, 14. By the way, I write this on past ocular history in Optomate. Highest pressures recorded were right in there. That way you can always see it. You don't have to go looking for them. So we went for Zalatan. The reason why, prostaglandins are going to give us our best chance of reducing. Why not? So Zalatan was what we went for. We went for a 30% target, and 8 weeks later, she still wasn't at target. So remember, the next thing to do is go, well, we didn't quite get to target. By the way, this is the time that you do need to definitely get the off-cell involved, because under the guidelines, if a patient doesn't meet target or needs intervention, further intervention, then you do need to make sure they get to an off-cell. I'd already written to Andrew and told him what I was doing and was following. So when the patient didn't meet target, we switched to Lumigan. That didn't help. It still was around that 14, 12, 13, 12. And then we moved to Zalocum. And we went in the morning. So does anyone want to tell me why we might have tried in the morning? And has anyone tried in the morning? Yeah, so the Zalocum with the timolol. Remember that the beta blockers work best during the day because there's not much of a sympathetic nervous system to block at night. The data around the prostaglandins is it's a bit patchy. So most studies say that nighttime prostaglandins are slightly better, but prostaglandins are taken in by the cornea and converted in the cornea. So you can almost think of them as a prodrug. And so nighttime is slightly better because that's they peak around 1 to 5 hours or 3 to 5 hours after putting them in, but they have a really long half-life. So you get the strongest effect within a couple of hours of, say, 5 hours of putting the drug in, but it does last for a long time. And there's a study that shows that there's, some studies suggest that perhaps Zalocum would be better in the morning. Others say there's no difference. In this case, we just had a crack and said, why not try it in the morning and see if we can get to target pressure. And after just 3 weeks on Zalocum, she'd met her target pressures. So really, I guess what I wanted to sort of have a chat about is this whole idea around how do we meet target pressure, how do we set target pressure, what sort of factors are you guys using now when you're choosing your target pressures? And it's a good thing to think about because, it's all right in an OSCE or whatever else to just pick a number. But I try for 20% in everyone. And anyone who's central, I go for about 30% because I figure why not? It's the best chance we're going to give them. We didn't image this one, or Andrew didn't image this lady. We've actually treated both eyes because that left eye, whilst the left eye was a little bit, are we sure, what is it, is it not? In the end, we just went, well, it's looking pretty suspect, so we gave it a hit as well. So are there any questions that anyone's got to want to ask, or anything you think you disagree or would have done differently here?
We're just waiting for questions to come through from the audience, James, so feel free to type in some questions into your question box while we've got our expert here. But we do have one question for you, James, in terms of normal tension glaucoma and neuroprotective agents. So there's been a bit of talk in the media lately about vitamin B12 being given patients with Alzheimer's and dementia, and there's an ophthalmologist around who's starting to prescribe B12 to their young glaucoma patients as a neuroprotective agent. Are there any other neuroprotective agents that you would consider or are aware of?
Yeah, so the B12 is thought to act as a cofactor within the electron transport chain as well, I think, and I think that's why it's thought to be neuroprotective. For a long time, there was this thought that alpha-GAN and the alpha agonists may be slightly neuroprotective, and it's never really been sort of shown conclusively, but I'm just starting a project with Simon Backhouse and Heathcote Wright, who's an ophthalmology, or he's a glaucoma ophthalmologist, because we're kind of thinking that perhaps alpha-GAN might be improving blood flow at the optic nerve head. So in as well as it reducing pressure, it might actually be bringing a little bit more blood to the nerve and therefore making things a little bit easier on the nerve. So yeah, there's in terms of neuroprotection, I know the B12 story is gathering some momentum, but there's not really enough evidence. Having said that, it's probably not going to do too much harm. And yeah, the alpha-GAN story is something that we're hoping to specifically have a look at.
And we've got another question from the audience, and it's talking about whether you treat one eye first to check the response from the drug, or whether you usually choose to treat both eyes at the same time.
So I don't bother too much with monocular trials. Because there's probably enough evidence now to suggest that there's enough spillover from the left eye to the right eye and vice versa anyway, through the systemic circulation. So I don't think it really does a great deal anyway. And for me, I kind of look at people and go, not sure if you've got glaucoma, come back in 6 months. And then when I'm sure they've got it, I treat. And so usually I treat both eyes. I guess the only people I don't treat are where you've got the secondaries and, one eye is absolutely fine, say uveitic or something. Otherwise, quite often you've got one eye that you're happy, like in this patient, you've got one eye where you go, yeah, that's glaucoma. And the other eye you're feeling worried enough about that you may as well treat. And, I don't see any disadvantage. And in fact, if you're going to use a prostaglandin long term, because the side effects include that orbital fat atrophy, if both eyes over a decade are receding slightly because you're losing orbital fat, you probably don't notice that much. But if one eye is and the other one's not, or it's 3 years behind, you can end up with lopsided looking patients. And so I think from a cosmetic point of view, you may as well, if you're comfortable, treat with both eyes.
And we've got another question from the audience about phasing IOP, and do you always use this as a baseline for your glaucoma management?
I try to, and the reason I do that is, so I look at these people and I go, I'm a bit worried, and I book them in usually for the repeat field or the field at the earliest appointment I've got. Like this lady was, what did I get, 9:08 or 9, so she was my 9 o'clock patient. So yeah, I just book them in for my first patient of the day and do the fields and the phasing. I don't phase throughout the whole day, as in get them to come in 6 times a day or anything like that. I just go for the earliest pressure I can get in the morning and ping that as the highest pressure. And someone was asking
about... Thank you so much for your time tonight, James. It was great having your presentation, really interesting for all our alumni to hear you present again. We're just going to hand over to Geoff now and introduce him.
Okay, so last but not least, we have Geoff Sampson, who is one of our senior lecturers at Deakin University, so he really needs no introduction. After teaching at Deakin for the past 6 years, his teaching and research interests are in paediatric vision development, binocular vision, and visioneuropathology. He developed Deakin Optometry's inaugural school screening program. This venture has simultaneously provided an important community service for children from underprivileged backgrounds and training ground for future paediatric optometrists. Over the past 12 months, Geoff has been part of a small team who have established a unique, evidence-based clinical communication training program for second and third year optometry students at Deakin. Thank you so much for joining us today, Geoff. I'll leave it to you for your presentation.
Thanks very much, Sarah, and thanks for coming along, everybody. We're going to talk tonight about diplopia, which is probably the most literal expression of double trouble. I will start by just talking about a few basics that help to give us an idea of what may be underlying a presentation of diplopia. And then we'll go into a couple of case reports that will hopefully highlight some of the traps that can occur if we don't look carefully enough. So diplopia, frankly, can be quite intimidating. Even for me, when I deal with it on a regular basis, it's still a challenge clinically if someone comes through the door telling you they've got a new presentation of double vision. Why? Most of the time, diplopia is going to have a benign cause that's not too threatening for our patients. But we need to remain aware that sometimes there can be pathological causes, and they may be quite threatening to our patients. So it's very important that we differentiate those two scenarios. And that's why it can be quite terrifying, because we know that there's always that possibility that this may be something that falls into the latter category, and therefore we need to know how to actually differentiate those scenarios. Even if it is something that's functional and benign, we're not always entirely confident of the management, because those are not things that we deal with in practice on a regular basis. So what do we learn if someone presents to us with diplopia? So firstly, we know that it's concerning them enough to report it. So that's a bit of a no-brainer, really. But I think it's important to understand they've come to us because they need help. So in some shape or form, whether or not we are someone who's got an interest in binocular vision or otherwise, we need to manage this somehow. But we also, from our own perspective, need to appreciate that when there's a recent report of diplopia, that something has changed for that patient, and that needs to raise our concern levels. So we need to be thinking of algorithms or ways that we can work through the possibilities of what might be the underlying cause. There's not much point getting worried about what the management is unless we recognise that the problem exists in the first place. So the key to dealing with diplopia presentations is to develop a sense of the underlying cause, or the likeliest underlying cause, and particularly to differentiate our benign from our less common but urgent, more threatening causes. So we can go through our normal way of doing this, where we are considering a lot of differential diagnoses. I'm sure you're all excellent at that by now as Deakin graduates. But frankly, there's 30, 40, 50 of these things, and it's not an efficient way of dealing with this. So for those of you with relatively normal colour vision, you'll see that some of those are green and some of them are red. The red ones are mainly the things that are potentially going to raise our concern levels more, where the green ones are a little bit more common and generally less concern for our patients. There's a lot of red ones there, even though that they don't show up all that often. So what we need is, instead of sitting there and thinking of 30 or 40 things at the same time, it's really not a functional or practical way to practice. We need to actually look for clues that will actually help us narrow that down to a handful of manageable differentials. So I'm going to take you to the Rio Olympics for a minute. If you're sitting there enjoying a drink in the sunshine and you're watching the women's marathon, and all of a sudden you see this scene come down the road towards you, you'd be forgiven for thinking that you've developed sudden diplopia. In fact, diplopia for this scenario would actually look like that, which is a little bit more scary again. But even if we saw that, we'd possibly be thinking, I've been sitting in the sun too long, maybe one too many gin and tonics. But these are, in fact, North Korean twins who finished 10th and 11th in the Rio Marathon with identical times. And if you look at their leg position, this is really synchronized swimming on the road, effectively. So if this was diplopia, though, we've got some clues already. These images are side by side, so it tells us when we have horizontal diplopia, all of a sudden a whole heap of our differentials have disappeared straight away. So this is really what we need to look at when we're assessing our patients' reports of diplopia to try and get it down to a manageable number of differentials. So instead of this, we need some sort of simpler algorithm which helps us work through these in manageable steps. So I like to break it all down to binary questions, basically. So it's either this or it's that. And if you can do that, all of a sudden, a whole heap of those differentials start to fall away, and you're left with a manageable number. So we should never ignore the possibility that this could be monocular rather than binocular diplopia. How do you tell? So if the patient's exhibiting this in your consulting room, you ask them to cover an eye. Ask them if the diplopia is still there. If they say it's gone away, then it's binocular. If it's still there, then it's likely to be monocular. We can ask them how far apart the images are. We can ask the patient to describe it. They can also draw it. We can utilize that as a way of getting information from our patients. They can be quite good ways of finding out the characteristics of what the patient's experiencing. So what are the implications? Monocular diplopia is actually surprisingly common. So in fact, if we don't actually ask this question, sometimes people are describing astigmatism, media opacities, dry eye, things along those lines that we don't need to be too worried about. We still need to manage them. However, if we confirm it's binocular diplopia, then we know we need a further true binocular vision assessment. And your next binary question to ask is whether it's concomitant or whether it's non-concomitant. It's a very useful next step. So again, if we're going to explore that question, how do we tell? So ocular motility obviously is the key to this. And I can hear you all groaning from as far away as Darwin. So here he goes again. Yes, I'm obsessed with ocular motility, but there's a reason for it because it answers this question for us really effectively. If we have subtle problems, then we can also use our cover tests in non-primary gaze positions. We underutilize this test as well. It will tell us changes when the person's looking in non-primary gaze positions that we may not get simply by looking at motility. And again, I'm stressing this a lot of times tonight, but we can ask the patient about the diplopia characteristics and whether these change with their gaze direction. That gives us a lot of information as well. If all of a sudden the images are further apart in left gaze, or there's a vertical element that develops when they look in right gaze, we have information that we may not be able to see easily with our motility test. What are the implications of this binary question? So concomitant strabismus is a lot less intimidating, particularly if it's horizontal in its presentation. Convergence insufficiency, divergence excess, combination esotropia, all quite common presentations, and none of them are all that stressful, and all of them can be managed by optometrists very easily. But if we confirm that it's non-concomitant, then there's a higher risk of this being sinister, and so our alert factor needs to go up substantially. We're dealing with nerve palsies, and if this has a vertical element in it, then we can start to apply Parkes 3-step to try and understand that. Or we're dealing with restrictive presentations. For example, something like a blowout fracture. These can be confusing, but if we think about our agonist and antagonist pairs, they become easier. If a blowout fracture traps our inferior rectus, then the superior rectus is not going to be able to move into its normal field of action because the inferior rectus won't let go. So this will look like a superior rectus palsy, but in fact, it's entrapment of the inferior rectus. Now, the third range of these is our higher order and our more scary diseases. These are brain diseases such as INO, internuclear ophthalmoplegia. So the non-concomitant ones we need to be much more careful of because they constitute most of those ones that came up in red on that earlier slide. So our third binary question is whether the presentation of diplopia is horizontal or vertical. How do we tell? So we can ask our patient in this case, and again, we can ask them to describe it, or we can ask them to draw it. It's a really helpful tool to get them to do that. It's a very important question, and the first case vignette I'll give you in a moment will illustrate why that's the case, because these can present quite subtly sometimes, and they can look like something else that's much more common. So cover tests, obviously, with subjective misalignment estimates as backups are important in this case. But if we want to tell whether something has a vertical presentation, a Maddox rod is a really useful tool because it allows us to measure vertical misalignment in a subtle way. Again, this will come into the first of the two cases. What are the implications of this horizontal versus vertical question? So if we answer this, our differentials change completely. So we really divide them into two separate categories, and there's not much crossover between these things. So if you look at the list we've got there on the slide of horizontal ones, and you look at the list on vertical ones, there is no crossover. So once we know the answer to this question, we've all of a sudden eliminated a lot of possible differentials. So let's have a look at that graphically. So if we have a look at this clock tower image, if someone comes in and draws or describes that, then we know we have a horizontal presentation of diplopia, similar to the Rio Marathon twins. Then we have a limited range of differentials that will explain that. If the patient comes in describing that, then we have a completely different range of differentials going to describe it again. And if this is the advantage of drawing, because if they draw it like that, all of a sudden we have a torsional element to this. And again, that's more likely to be pointing to something like a fourth nerve palsy, where we know that there will be torsional change in a presentation like that. So we've narrowed this down to a very small number of differentials if that's the way the patient draws it. We ask them to describe it. They may not tell us about the rotation. One to be careful of is this. So if they present it like this, then we've got a very subtle vertical element and a more prominent horizontal element. Then we'll often miss that clinically because the vertical change there is not going to be discernible with things like cover tests. Cover tests is not subtle enough to pick it up. So we're going to look like we have a horizontal misalignment, where in fact there's a vertical element there as well. So the importance, again, I want to stress of ocular motility in the, yes, I know I hear the groans again, but I want to stress the importance of this because if you look at something like this presentation, which represents internuclear ophthalmoplegia, if you look at the patient front on from far enough away, they will look perfectly normal in primary gaze. Get them to look to the right and it's okay. But if they have a right INO and they try to look to the left, then we'll find that the right eye does not adduct, and then the left eye will just develop nystagmus in response to that. We're not going to see that with primary gaze assessment only. And then in more general terms, the importance of assessing competency. So if we can confirm non-concomitant strabismus and it's accompanied by any or all of the following signs, then we have an emergency on our hands and we need to get that person into high-level care almost immediately if that's the case. Recent onset diplopia, headaches, other signs of illness, personality change, which is usually described by someone other than the patient themselves, or papilledema. These are showing us that we have serious brain disease in these cases. They need urgent referral for neurology workups. Case vignette 2 will talk you through a case that represents the importance of this. So let's have a look at the first case. 23-year-old female presents with recent onset diplopia. You do a very simple assessment and you find an 8 Prism Doppler exotropia with a near cover test. There's no sign from your cover test of any vertical misalignment. So it's very easy in this case to make an assumption that this is a decompensating convergence insufficiency. This is how they present, basically, even though this is a fairly small angle one. Why? We've got an apparent horizontal exotropia at near, and we know that the prevalence of convergence insufficiency is very high. So it looks highly like that's our problem. But if we leave it at that and we don't look further, then potentially we miss signs that we need to be able to process and pick up. So the patient, in fact, looks like this. Big deal. So what's wrong with this? Presumably, hopefully people can see the pointer here. Thank you. So if you have a look here, we take a line through her pupils, then she's actually got a head tilt to the right. And if we look at the side of her nose there, or how much we can see on the side of her eyes at either side, if she had a hairstyle like mine, we could see her ears. We'll see that this woman's got both a head turn and a head tilt to the right. Very subtle. So people think that this sort of presentation comes in with the person's sort of head, at 90 degrees to the rest of their body. But in fact, that's not how they come in. So if we look at that, that shows the importance of looking carefully with our external exams. So if we go a little bit further and we use our Maddox rod, we actually find a 3-prism diopter left hyper misalignment. Now, we're not going to see that with a cover test because it's too small. 4 is about the minimum we're going to see. So that's our first Parkes step in this case, just to ask which eye is actually higher. So this increases to 6 prism diopters in right gaze. So straight away we know we have a non-concomitant strabismus presentation because the magnitude has changed in direction of gaze. It's dependent on that. That's what defines non-concomitancy. So a careful history. Following that, the patient admits to falling from a push bike 3 days earlier and developed diplopia 24 hours after that particular injury. So a targeted history again gives us further information here. And when we look carefully with motility, we realise that there is a limitation of left eye depression in adduction. And these things don't jump out at you. They are subtle, but they're there if you look for them. So we've got a whole heap more information now. So I'm sure, well, I hope, given that I taught most of you this, that you realise now that we're dealing with a left fourth nerve palsy in this particular case. They are very common, and sometimes injury, head injury or neck injury is an underlying factor in a lot of these cases. Why, though, does it look like an exotropia? Because that's really what this would have looked like clinically if we didn't look a bit further. So to answer that, we have to think about what we do when we use a Hal Dwyer card. Whenever we put a 6-prism diopter base down right in front of somebody, we are breaking their fusion. And as soon as we break their fusion, they are going to exhibit or manifest their horizontal misalignment. So if we're breaking, this woman's fusion is broken by her 3-prism diopter left hypermisalignment, then she's going to show her exophoria as an exotropia. We're going to see that straight away. So this is not an exotropia primarily, and the management of this is completely different. We're going to need to have a look at things like vertical prisms to try and realign her, and she will use her own head tilt and turn to chop, manage that as well. There's no point giving this person horizontal vision therapy because we're not going to solve the underlying problem in this case. So case vignette 2, and I have to warn you with this one, unfortunately this is a true case and probably won't end the evening on a particularly happy note, but I think it's an important one, and so we'll work through it relatively quickly because we've used up a fair bit of time already. 10-year-old male presented with 2 weeks history of diplopia. This diplopia was horizontal on questioning. It was intermittent, but it had been increasing in frequency over a period of time, over that 2 weeks, I should say. They also reported a 3 months history of headaches, 3 to 4 episodes a week. It was a deep type of pain, but remember this was a 10-year-old male. He was highly intelligent, but he was unsure of the location, couldn't get a pattern for that. Sometimes admitted it was on waking, and sometimes it just goes away by itself. The GP had investigated the headaches but found no explanation for them, and there was no history of head trauma. But of interest, I hadn't seen this patient personally before, but they were a patient who'd been at the practice previously, and they had been wearing a full-time RX for 3 years of +2 right and left. So this child had normal vision on both sides with their current glasses, but they had a 15 to 20 prism diopter esotropia at near and distance in primary gaze. It was constant, distance and near alternates, but preferred right fixation. Motility showed a full range of movement in right and left when we did it with adductions particularly, which is important for ESOs, otherwise you can't usually see the full range of movement on one side. So the esotropia in fact appeared to be concomitant. So from that alone, alert levels tend to drop a little bit. Even more so when dry ret showed there was some uncorrected plus there. And in fact, we had about 3 diopters there, but in fact it took nearly 4 diopters right and left to get this child back to binocular single vision. So no diplopia, gross random dot stereopsis, and a small residual esophoria. Ocular health exam was unexceptional, with optic nerve heads looking looking healthy and well defined and well perfused. So the diagnosis here is pretty obvious. We have an accommodation esotropia that are decompensated secondary to undercorrected hyperopia. Management just gave them more plus at near. They wouldn't take a full amount at distance. And as a 10-year-old, they were given a pair of occupational multifocals. Asked to come back in a month, but told to call earlier if the diplopia or headaches persist in the interim. Now, I still don't know. This was 20 years ago that I saw this young man. I still don't know whether it was clinical intuition. It was probably clinical fear. But something just didn't seem right to me in that presentation. And I initiated a call to the family a couple of days after the new glasses were collected, which was probably a bit over a week after I had first seen them. The mother told me straight away, said, "Oh, no more double vision going on, but he's closing one eye all the time now. Should I be worried about that?" So it kind of explains the lack of diplopia when that child's doing that. But she also admitted this child had been having severe headaches and vomiting for all that day. So this didn't sound all that healthy to me, and we brought them back in that afternoon. We had a look at them. I say we because I brought one of my colleagues in. I was a bit terrified at the time. Very different clinical picture. So this child had a head turned to the left, 25 to 30 prismed optic esotropia in primary gaze with their new glasses on, which was meant to get rid of their esotropia. Versions indicated it was now non-concomitant and the esotropia increased in left gaze. Ductions confirmed there's a limitation of left abduction. So this is an entirely different clinical picture than what they had exhibited a week before. Visual acuities were still okay, and the internals also were not showing anything too dramatic there either. This was a very clear, by now, left sixth nerve palsy, and the child was referred for immediate evaluation by a paediatric ophthalmologist, who referred also fairly quickly to a neurologist. Unfortunately, this child had quite an advanced glioma of the pons, so brainstem tumour. And despite some aggressive treatment, we found out via the family that 3 months later the child unfortunately passed away, which was an awful outcome for the family in particular. So it's a very hard way to learn a lesson, but there was a lot of lessons involved clinically in that presentation. It was an atypical one at start. The abduction deficit of the sixth nerve palsy was not evident, and it was masked by an apparent perfectly good other explanation for that child's esotropia, in that they had undercorrected plus, and they did have an accommodative element to that. There's an absence of things that we might think about as accompanying neurological signs: papilledema, endpoint nystagmus, and no esotropia greater at distance than near, which is what we often see with sixth nerve palsies. But it's a tragic but powerful lesson about the importance of recent diplopia and headaches being highly suspicious, and variability in strabismus presentation also being highly suspicious. We need to be alert for comorbidities in these cases. Sometimes there's more than one thing going on. And it's also a good lesson to trust your clinical intuition. If something doesn't seem right, you need to actually follow it through. Thankfully, I did a week later, but unfortunately, that still didn't manage to save this child's life, which was awful. Mostly sixth nerve palsies are not as dramatic as that. A lot of them will recover spontaneously. Older people, it's often diabetes and hypertension, but we have to be aware of those possible worst case outcomes. And I think that's probably all for tonight, and I'm sorry to end on such a depressing note, but I think it's an important lesson in this particular case.
Okay.
Thank you for listening.
Thank you, Geoff. That was very good. It's now time for our discussion session. So for all our listeners, you can take some time now to type in some questions for Geoff, and we can ask them now. Is it here?
So I think our first question, Geoff, would really tie into your communication expertise that we could lean off. And I noticed that in your presentation you said they might have subtle personality changes when some of these cases present. Could you give an insight to what they might be, or how we might pick up on that in a consultation?
Okay, that's a great question, Amanda. I think in these cases, generally it's dependent on having someone else with the patient, because patients, to my understanding, I haven't seen a lot of this personally, but I certainly have read a bit about it for these sort of cases. Often if you are asking subtly a person who's not there, who is there with the patient concerned, whether it's a child or whether it's another adult, sometimes you'll have to do that in a subtle way outside the room. They will often tell you that the patient doesn't see themselves in a case like that, and that can be a subtle sign of, unfortunately, brain injury that can go on in those sort of cases.
Excellent, Geoff. So we've got a question that's about a patient someone had recently where they got diplopia for about 20 minutes after having an MRI, and they haven't seen any diplopia since. Have you ever heard of people getting diplopia post-MRI before?
No, that's the first time for me, so I don't really... If that person concerned has an easier question, that would be much appreciated. Yes, no, unfortunately, I don't know what the scenario that would be in that case. If the person concerned is still online and able to type in, what do they know the characteristics of diplopia? Horizontal, vertical?
Horizontal.
Horizontal. Don't know. I mean, it may just be perhaps that may be a true decompensation. I've never been in an MRI. This is your area, Amanda. You know this a lot better than me. But you know, if you haven't got something that's easy to focus on in a case like that, sometimes those things will just unravel if there's just a subtle CI. But I truly don't know the answer to that one. That's a really interesting presentation.
Great. We've got another question here for you, Geoff. It says, I recently read a study that suggested more than 90% of suspected divergence insufficiency in kids is actually ended up being a partial sixth nerve palsy. Yep. What do you think of these numbers?
I think that that's really good advice. It's one of the things we didn't have much time to go into tonight. Ash and I have seen a few of these that we've been concerned about on vision screenings, but in fact it's very unusual to get a divergence insufficiency pattern. The other three combinations there are quite common, but sixth nerve palsies do present with a greater ESO at distance than near, because the person's not able to diverge fully when they look up in a case like that. So whenever we see these, we need to be really suspicious of it. So I didn't know those numbers, but they don't surprise me. And if you've got that and a kid with a headache who's unwell, that's potentially an emergency. Well, that is an emergency until proven otherwise.
Excellent. We often also have students ask us when we're in clinical skills what the best way is to measure a distance foria. So what would you recommend?
Well, there's a couple of ways. So I think if it's a horizontal foria, then you can get away with things like Maddox rod. You shouldn't use them at near because they don't control accommodation. But really, if you don't have a distance Haldry card, which is probably the easiest way to do it, then I think really Von Graef is the way to go about that. So it works through a trial frame, it works through a refractor head. It's quite useful.
Good. Thank you again for your time, Geoff. So that's all we have time for tonight. Thank you so much to our presenters for making such valuable contributions to our second webinar. It's been very interesting, and thank you to our listeners for tuning in and participating in tonight's webinar. We hope you've really enjoyed it again, and we're looking forward to it next time. So next up for you, we're actually going to be bringing out an alumni magazine, so keep an eye out for that on Facebook. And as always, if you're interested in contributing, we would be happy to hear back from you and hear any feedback you have for us. That would be great. Please feel free to provide any feedback regarding the seminar and the presentations and the presenters themselves through the survey on the, I believe it's the Qualtrics that was emailed to you. The alumni committee would love to hear from you, so feel free to reach out to us at any time. We would be really interested to hear about what topics you would like for us to focus on next. So the next step for you now is to fill out your CPD questionnaires to earn your CPD points. As I mentioned earlier tonight at the start of the webinar, we will be using InterDashboard. Some of you may have used this at Deakin for CPD activities before, and so the email to log in would be the same as the last one, the one that you would have used for Pediatric Insights. So this would have been made from the email that you registered with for tonight's webinar as well, if you hadn't come to any previous webinars. If you are new to the dashboard system, you would have been sent an email with your password. If you have lost this email, please contact one of our alumni committee members. So Lucy and Ash would be more than happy to help you with that one, to help you reset it. Once you have followed this link, you can change your password to something that you will actually remember. The quiz actually will be available for the next week or so, so don't panic if you don't get it done tonight. So that'll give you plenty of time to finish it. If you attended our last webinar, as I was mentioning before, the Pediatric Insights, you can use that same email to log into the InterDashboard system. Thank you again for joining us, and until next time, goodbye from the alumni team here at Deakin Estate, and thank you again for your continued support.